Hi, this is Jim Bussell and Howard Liebman to present this session on transforming the quality of care for patients with immune thrombocytopenia, or ITP. Howard and I come from opposite ends of the country and have different perspectives on our approach to ITP, so that hopefully you'll be able to get the benefit of both of those during the course of this session. These are the disclaimers because we will be discussing medications that are not licensed for some of the uses we're going to be covering. We will be trying at all times to present the best available evidence in regard to our comments, and we'll try to go from referencing a controlled trial to saying that this is just our opinion based on the strength of the evidence available. We both have conflicts of interest listed on this slide. The simplest thing I can say is we both have many different conflicts in the area, so I don't think either of us feels particularly affiliated with any one of them. In the overall program, we're going to have a short introduction, most of which we've covered. We're going to be talking about understanding immune thrombocytopenia, or ITP, particularly symptoms and diagnosis. We're going to review different treatment options. We're going to have some interactive clinical case challenges to go over with the audience. And finally, we're going to finish up with a brief discussion of strategies by which we can help patients deal with their ITP. We've identified a number of learning objectives which we hope we will achieve during the course of the program. They all relate to various facets of ITP and to some extent match up well with the agenda that we just reviewed. So I'm going to start off by going over understanding ITP, talking about the symptoms it can cause and how to make the diagnosis. So this slide illustrates the pathophysiology of ITP. I would say the main thing that's missing here is some of the more complex immunology. In other words, for example, there's no indication on this slide of the role of activated T cells. But if you start on the lower left of the slide as you're looking at it, you can see there's a megakaryocyte in the bone marrow. We no longer think that platelet production is increased because, as indicated by the light green antibody, that antibody may be damaging the megakaryocytes or at least preventing them from releasing platelets. It's possible if they release platelets that antibodies in the bone marrow will damage or destroy the platelet before it ever gets in the peripheral blood. Once it gets into the peripheral blood, we think it's bound by the FAB portions of the antibodies. We think it achieves a multi-point attachment of the antibodies and is illustrated in the slides of the macrophage with the black Fc receptors. It's irreversibly bound to the macrophage by virtue of this multi-point interaction. Another area that's missing from this slide is the relative importance and differences in the various types of Fc receptors and how they signal. We also have a little box on the left for thrombopoietin, which is intended to indicate that, relatively speaking, despite the thrombocytopenia, the level of thrombopoietin is not particularly increased, So one could think of ITP as a relative thrombopoietin deficiency. It's also clear that there's many different steps where therapeutic interventions could take place, from the bone marrow, either interrupting the antibodies in the bone marrow or stimulating production of more megakaryocytes and more platelets, interrupting the attachment of the antibodies to the platelets, or blocking the interaction of the Fc portions of the antibodies bound to platelets with the Fc receptors of macrophages. In principle, we have now come to believe that there may be differences between different platelet antibodies and how they act. It's generally agreed on that antibodies to glycoprotein 2b3a appear to destroy platelets, as illustrated on the previous slide, with binding to Fc gamma receptors, for example, Fc gamma R3a in macrophages. In contrast, there is a growing school of thought based on a number of studies in mice primarily, but also in people, that antibodies to glycoprotein 1b9 may act to desilylate platelets, which means to take a terminal sialic acid off the glycoprotein 1b9, and by exposing a galactose, this then leads the platelets to bind to the Ashwell-Morrill galactose receptor in the liver, and not only are the platelets thus destroyed in a different fashion, but this form of destruction may stimulate thrombopoietin production. This is still somewhat controversial, but as indicated, there's a growing body of evidence in favor of it, and this was well described recently in a review in Blood by Hoffmeister. We know that a number of different cytokines, as illustrated by this slide taken from a New England Journal paper by Ken Kashansky, that there are a number of factors which are thought to influence megakaryocytes at different stages. But you can see in all of the different legends thrombopoietin, and it's thought that it is the most important. Furthermore, some of the other factors, or even possibly all of the other factors, are thought to have their influence by upregulating or downregulating, in this case upregulating, thrombopoietin. When you get to mature megakaryocytes, it's a little less clear as to what the role of thrombopoietin is, but it appears that it will stimulate megakaryocytes to release platelets as well, and thus have a direct effect to increase the platelet count. This slide illustrates the conundrum about thrombopoietin levels in ITP. Platelet counts are in green, and thrombopoietin levels are in yellow. So if we start on the left side of the slide looking at healthy donors, they have a normal platelet count above 200,000, and we can see that they have a very low thrombopoietin level. In contrast, amegakaryocytic thrombocytopenias, where there's no megakaryocytes in the marrow and no platelets being produced essentially, and no platelet turnover, have very high levels of thrombopoietin and very low levels of platelet counts. However, when you have ITP and you have very low levels of platelet counts, in this condition the thrombopoietin level is barely greater than normal. And we believe that that's due to the fact that platelets and megakaryocytes have thrombopoietin receptors on them, and if they are present, then a lot of the thrombopoietin, whether endogenous or even exogenously administered, like the thrombopoietin agents, will bind up the thrombopoietin. There will be relatively less to act on the stem cell and the megakaryocyte progenitors. In contrast, if there are no receptors in the circulation and in the marrow, like in amegakaryocytic thrombocytopenia, the thrombopoietin level is high because there are none of these receptors to bind it. The recent work described by Hoffmeister in terms of the potential positive loop effects of GP1B9 antibodies binding to platelets and causing them to be destroyed via the Ashwell-Morrill receptor and upregulate thrombopoietin has to be integrated into this model. There's new terminology for ITP. You can see on this slide that purpura was removed because some patients don't have bleeding symptoms. In addition to achieve uniformity so that papers could be compared, the terminology is now newly diagnosed for 0 to 3 months, persistent for 3 to 12 months, and chronic for greater than 12 months. In addition, severe ITP would require that there be some active bleeding, and refractory ITP would be reserved for patients who have undergone and not responded to splenectomy. Symptoms are often different kinds of bleeding. Petechiae, the little red dots that look like they were placed by the tip of a pen and don't blanch the way angiomas do. Ecchymoses or bruises. Could have epistaxis, gum bleeding, especially when stimulated, and then various other bleeding signs or symptoms. Mouth sores or little, quote, sacks of blood, unquote, off the buccal mucosa are usually a sign of very low platelets and a potentially increased risk of serious bleeding, such as the worst bleeding, which is an intracerebral or intracranial hemorrhage. On another note, there may be fatigue in a significant number of patients when their platelets are low for not yet completely discovered reasons, and ITP, although it's a thrombocytopenic hemorrhagic disease, may be associated with thrombosis. There's also an interesting take that's been developed over time in regard to infections in ITP. Traditionally, children develop ITP after routine viral infections. The infection is cleared, but the immune response to the infection may lead to thrombocytopenia for weeks to a month or two, and this may account for cases that resolve spontaneously. However, in HIV, which has a thrombocytopenia and that is in many ways similar to ITP, the HIV is a persistent infection, and while there is an active infection, the platelets may remain low. However, in a very high percent of cases, if the infection is suppressed and the viral load goes to 0, the platelets will go up, as indicated in the smiling faces. The hepatitis C story remains to be worked out, but seems to be a little disappointing in that eradication of hepatitis C does not seem to be synonymous with increases in platelet counts. Helicobacter pylori is even more confusing because if one has Helicobacter pylori and thrombocytopenia, especially in Japan or Italy, treatment and eradication of it will usually lead to an increase in the platelet count, which is not true in general in the United States, although there may be certain small populations, especially of immigrants, where that may be true. And finally, another virus that has an infrequent presence but can cause severe ITP is CMV, and if it's recognized and eradicated or suppressed, platelets will just about always increase. So this is a different way of looking at infections and ITP. Secondary ITP can occur in a number of causes. One of the more common is common variable immunodeficiency, and it appears that rituximab in these patients is a particularly good treatment as eradication of infections is a good treatment in those described on the previous slide. Finally, for differential diagnosis, there are many possibilities. The usual rule of thumb would be to distinguish a case where the primary finding is low platelets and any bleeding symptoms associated with that from cases where there are also circulating blasts, where the white count of the hemoglobin are abnormal, where there may be hepatosplenomegaly or lymphadenopathy, and so on. The most difficult to distinguish is usually inherited thrombocytopenias, because these may have isolated thrombocytopenias as well, at least superficially, when first examined. If the platelet count is less than 100,000, in the absence of other abnormalities, i.e. in red cells, white cells, hepatosplenomegaly, radial rays, and adenopathy, and the patient is generally healthy, the leading diagnosis to suspect would be ITP. The typical thing to say is that there be no other cause for the thrombocytopenia. However, for example, some of the infections described above or common variable immunodeficiency may not have other findings that you would expect, i.e. patients may not have gastritis and in CVID not have any history of infections. So how much workup to do depends on individual preference, although there's some consensus that hepatitis C and probably HIV should be specifically looked at and excluded. All of these things, however, are ways of excluding diagnoses other than ITP, and the primary way to actually establish the diagnosis is if a treatment is done, such as IV gamma globulin, and the platelet count goes up dramatically, even if it does not stay elevated for long. Now we're going to go over and look at treatment options for ITP, and Dr. Liebman's going to take over.
Thank you, James. There are obviously a number of treatment options available, and based upon an analysis by the International Working Group of physicians who specialize in this disorder, the decision has been made to separate those into the initial or treatment options and then subsequent secondary alternatives if patients do not develop a unmaintained or complete remission. We do not seem to be. There we go. So first of all, in deciding in regards to treatment options, one should consider the patients, both their personal goals and their lifestyle in regards to what choices one makes for their treatments. One has to assess their presentation and the severity of ITP, and that can be done by your initial physical examination, which is quite important, along with the evaluation of the peripheral smear in all patients who present with low platelets. The classic finding is evidence of mucocutaneous bleeding. As previously stated by Dr. Bissell, some patients may have significant thrombocytopenia with almost no manifestations of bleeding, but the classic findings are those that involve the development of petechia, the small red dots that may occur in areas of pressure, or ecchymoses, larger bruise-like evidence of bleeding, and both old and new lesions that may occur if patients have had these manifestations over time. Further manifestations include mucocutaneous bleeding in the mouth and epistaxis, and in fact more severe separations of the buccal mucosa with hemorrhagic bullae, which, as stated previously, may be a significant sign suggesting a greater risk of more significant bleeding. Now, with consideration of those, usually we assume that the platelet count is going to be less than 30,000, and frequently it's even less than 10,000. But as stated previously, One needs, of course, to consider the other fact that many patients may have medications that may, in fact, reduce platelet function. So an elderly person presenting with platelet counts of 30 or 40,000 who's also taking aspirin or platelet inhibitory drugs based upon prior history of cardiovascular disease could present with significant ecchymoses and bruising and platelet counts under 50,000. The most serious complication is intracranial hemorrhage. It's been reported to occur in approximately 0.1 to 0.5% of cases in the pediatric population, and often this is followed an episode of head trauma. While in adults, the incidence tends to be higher, but in particular this occurs most often in older patients who are frequently refractory and even post-splenectomy refractory. Now, the incidence of fatal bleeding is predominantly linked to the development of intracranial hemorrhage, and with the advent of the thrombopoietin receptor agonists, there is a suggestion that these fatal bleeding events may be on the decline. Bleeding is uncommon in patients with platelet counts greater than 30,000. The consideration of the therapeutic approach to ITP must consider both the initial manifestations of bleeding when the patient presents and the significant risks that those bleeding events can incur, but also the long-term outcome and goals of the patient. For example, when patients have obtained an initial response to therapy, they may require higher platelet counts for other interventions such as dental extractions or biopsies. And occasionally minor interventions may only need to increase the platelet count to greater than 50,000. Women who are pregnant and wish to undergo a vaginal delivery and have epidural anesthesia, this usually can be performed safely with platelet counts greater than 70,000. Other patients who require major surgical interventions may have to have their platelet count increased to greater than 100,000, and a therapeutic approach that requires sustaining that high platelet count in the immediate post-surgical period. Consideration of treatment modalities also have to include consideration of not only the patient's preferences, and that includes impact on family lifestyle and daily work, but also consideration of the patient's comorbidities. The use of corticosteroids may negatively impact the control of diabetes mellitus. The use of intravenous immunoglobulin puts patients with significant coronary vascular disease at risk of coronary vascular events. And the use of other agents could impact renal function. Patients will want to know in regards to individual therapies what would be the duration of response. Do the patients require continued use of an agent? What are the toxicities? And also, what is the cost of this particular therapeutic agent? Initial treatment options for immune thrombocytopenia, as recommended by a variety of guidelines, include the use of corticosteroids, intravenous immunoglobulin, and another choice available now in the United States, no longer in Europe, is anti-RHD immunoglobulin. In summary, corticosteroids, and classically the choice was prednisone in milligrams per kilogram given once daily, resulted in about a 60 to 85% response. Less than one-third of patients having at least a platelet count that is sustained at 1 year greater than 50,000. Intravenous immunoglobulin, the initial treatment dosing being 400 milligrams per kilogram given over 5 days, has been changed to a more common giving 1 gram per kilogram over 2 days. The dosing should also consider such factors as the age of the patient and whether the patient has other cardiovascular risk factors. The usual response rate is about 70 to 75% of individuals, but only a small number of these patients obtain a sustained response. Anti-RHD, given in doses at 50 milligrams or 75 milligrams, may have a response similar to intravenous immunoglobulin, but a risk of immune hemolysis is associated, although in most of the cases, it results in only a minimal decrease in the patient's hemoglobin. In summary, looking at 3 large clinical trials with greater than 250 patients in each of these trials for chronic immune thrombocytopenia, the initial response to standard corticosteroid treatment, prednisone at a milligram per kilogram, ranged from 65 to 70%, respectively. The median time to response for a platelet count greater than 100,000 was usually 7 to 10 days, and at times requiring durations of greater than 14 days in some patients. However, at 1 year, only 13 to 17% of patients remain in remission, unmaintained any alternate therapies. A newer regimen that has been incorporated includes the use of high-dose dexamethasone. The use of dexamethasone, 40 milligrams a day for periods of up to 4 days, was initiated initially in studies of multiple myeloma, and a trial that was reported earlier in refractory patients in the New England Journal. However, recently it's become an alternate choice as opposed to a standard prednisone for initial treatment of immune thrombocytopenia. In a trial reported by Cheng in the New England Journal of Medicine, a single 4-day course of dexamethasone for patients who had platelet counts less than 20,000 or less than 50,000 with bleeding manifestations. The initial response rate was close to 85% who obtained a platelet count greater than 50,000. However, over half of those patients relapsed within 6 months. Additional treatment options that are taken with the use of high-dose dexamethasone have been to extend the repeated cycles out to 4 repeated cycles in a study from Italy, showing a somewhat higher platelet count, unmaintained platelet count at 1 year, but evidence of long-term unmaintained remissions have not yet been published, so it's unknown whether this, in fact, results in a higher long-term remission rate. There are common toxicities of corticosteroids. The most important is patients who have evidence of glucose intolerance and diabetes, particularly the use of high-dose dexamethasone, can result in radical increases in serum glucose. There's also always an increased risk of infection, particularly with long-term use of corticosteroids, in addition to osteoporosis, and particularly this may be quite severe in postmenopausal women. And there's always an effect of weight gain and body changes, which are ungainly and unattractive, particularly in a younger individual. Intravenous immunoglobulin has been shown to be effective in raising the platelet count in at least 70% of patients within 24 to 48 hours. To date, this really remains the most rapid therapeutic option in raising platelet counts in patients with very severe thrombocytopenia and bleeding manifestations. It works in patients with and without spleens, but it has very short duration of responses, usually 7 to 14 days at the most, and the infusions are quite long and can be associated with infusion reactions, including a more rare severe anaphylaxis, and even occasional thrombotic risk as mentioned previously, and a severe complication which is quite anxiety-provoking for the physician is the development of an aseptic meningitis, where patients present with what they frequently describe as the worst headache of their life, and for that reason there's always the anxiety of having utilized this therapy in a patient with thrombocytopenia. Is this a complication of the intravenous immunoglobulin, or are the patients having an intracerebral bleed? In addition, the cost is quite significant, and the repeated use can result in significant expenditures of patients' money. Anti-RHD can result in a similar response rate of about 70% in patients. Responses at 50 micrograms per kilogram tend to be somewhat more delayed, closer to 72 hours, but studies suggesting a higher dose equal to that seen with intravenous immunoglobulin. It does not work in patients who have had their spleen removed. Significant toxicities have been reported, including fatal events from intravascular coagulation and hypotension and shock. Patients who can develop, particularly in the higher doses, significant hemolysis with kidney failure, and in fact it should be patients with some renal injury should not receive this treatment. And with significant hemolysis, it may contribute to anemia, particularly with repeated use. And there are some infusion reactions, although usually these can be well managed.
Howard very nicely outlined the role of other therapies in ITP and allowed me to discuss the issue of some of the other treatments after first-line treatments have been used and either not worked or do not seem to be appropriate to continue with. And we're going to discuss some of these treatments, TPO agents, rituximab, splenectomy, and how you might choose between them. So a patient comes to you with severe chronic ITP. Maybe they wouldn't be chronic by this time because they likely would have had other therapies, but let's say they've been on steroids for a number of months, maybe they're really persistent, and asks, what should I do? You look at the patient and say, what do you want to do? And the patient isn't very sure. So you decide to help them out by approaching them from the point of view of what questions each treatment might answer. So you say, if you want the highest cure rate, it's probably splenectomy. If you want to be cured but you don't want to undergo splenectomy, probably combination of dexamethasone and rituximab. And if you want the best chance of having a good platelet count and are willing to put up with taking medication regularly, given that it doesn't have a lot of toxicity, then the answer would be the thrombopoietic agents. So the patient may have failed initial courses, although failed may include transient responses with prednisone and IVIG. They're now 6 months into their ITP, and the platelet count is down to 13,000, and they're having bruising and some nosebleeds and some gum bleeding with toothbrushing. And even though they've been tapering their prednisone, they're still on 20 milligrams daily. So there are immunosuppressive agents, danazol, dapsone, that could be used. The TPO agents, rituximab, and splenectomy, probably the best options. So what about splenectomy? It's probably overall the best way to cure ITP with a 60-65% long-term cure rate. There are risks of the surgery itself, including infection, thrombosis, and bleeding. There's a lifelong risk of overwhelming post-splenectomy sepsis, where if the patient gets a bloodstream infection and it gets out of hand, they may get very sick very rapidly because they're not clearing the bacteria from their bloodstream. Increasingly, it appears that there may be other long-term effects, for example, thromboembolic effects in one way or another. Finally, while we in general cannot readily predict the success of splenectomy, it appears that a platelet sequestration scan can either say there's at least an 90% chance of success or a less than 30% chance, depending on whether the platelets are sequestered almost entirely in the spleen or, for example, in both the liver and the spleen. This test, by the way, is not currently done in the United States. This slide shows the best long-term outcome data and the best long-term outcomes of splenectomy, and you can see in the lines on the top where it says CR, or complete response, that these patients are almost 80% in this particular study, and they're followed out for 4 decades, which is quite a lot. However, to be fair, that's the most optimistic study, and this shows not a response rate, but just how often splenectomy is done. And you can see that through 2009, the rate of patients with ITP having splenectomy in one healthcare system went from about 30% of patients in 1993-4 to less than 10% of patients in 2009, and it may still be going down further, showing that patients and physicians are not enthusiastic about splenectomy at the current time. I'm not sure that this is the reason, but there's some national registry studies, for example, one from Denmark, showing, as mentioned, increased thromboembolic events, including strokes, after splenectomy, although none of these studies are randomized, so it is hard to be sure that the groups are comparable. We believe that since sepsis is relatively rare, even in splenectomized patients, it may be especially important to consider an underlying immune deficiency, and the classic patients that develop overwhelming post-splenectomy sepsis are those with unrecognized Wiskott-Aldrich, as an example. So it's very important to consider this and CVID in patients before going to splenectomy. Now we have this same patient, and the treatment courses have failed, and it's the same overall situation. Now you're out at 9 months, and splenectomy didn't work either. And so what are the options? And again, we could consider the TPO agent and rituximab. For rituximab, people used to think that this was the best way to cure ITP. However, Ganima, in a randomized study published in The Lancet in 2015, showed that rituximab alone was no different at 1.5 years from initiation of therapy from standard of care with prednisone. This confirmed a previous study from our group in Blood in 2012 that took responders to rituximab and looked at their long-term outcome and found that overall the long-term relapse-free outcome past 2 to 3 years was only 20 to 25%, which might be the natural history of waiting that additional time anyway. So it seemed that the use of rituximab might be becoming discouraged, but Zaya in Italy and Gudbrand's daughter in Denmark looked at rituximab with dexamethasone, thinking that the use of an agent that attacked B cells, namely rituximab, and plasma cells, namely dexamethasone, would be a good combination. And it seemed like a good combination, although the long-term outcome of 36% was not ideal. Shorter-term outcome comparing the efficacy to dexamethasone was very good, as can be seen in the slide of both the studies, but unfortunately there's been no comparison of dexamethasone and Rituxan to Rituxan alone, which would be ideal from the point of view of demonstrating efficacy. Now we know that patients who are close to diagnosis do better, and as indicated, perhaps 40% of patients achieve an initial remission, a CR, but only 20% have a response lasting long term. We believe from a single-arm study we published in July 2014 that rituximab plus dexamethasone, when you use 3 cycles of dexamethasone instead of 1, is clearly superior to rituximab alone. And it's worth noting that since response to rituximab may be delayed, the dexamethasone in the first 6 weeks helps to make the count go up while you're waiting to see if this will happen. The adverse events are primarily inability to vaccinate and very rare viral infections. There are now 2 cases of JC virus known to have occurred in ITP patients, but in one of them it was more than 3 years and many different other therapies later. So unlike the setting where rituximab is given with high-dose chemotherapy for lymphoma, for example, this seems to be a very rare effect. When you combine the DEX in 3 cycles with rituximab, hypogammaglobulinemia occurs more often, and 10 to 20% of patients may require low-dose IVIG. And there are other reactions that are either not serious or infrequent, listed on the bottom line of the slide. So in this particular case, it seemed reasonable to try this, but in this particular case, it didn't work. And now we have the same patient, and while we could try immunosuppressives or danazol or dapsone, probably by far the best response would be to the thrombopoietic agents. There are 2 agents. One is called L-Thrombopag, although the brand names in the U.S. are Promacta and in the rest of the world Revolade, or Romoplastin, and the brand name in the U.S. and the rest of the world is Nplate. These will be effective in even 60 to 90% of difficult refractory patients like the one just described who didn't respond to either rituximab with dexamethasone or splenectomy. In general, the count will only increase as long as treatment is continued. Some patients may be able to discontinue treatment and taper off the agent, but it's not clear how many or how to select the ones that it will be. These agents were licensed in 2008 in the United States, and now each is licensed in greater than 90 countries. After licensure in the U.S., the FDA used a REMS program to monitor the outcomes carefully in many thousand patients over 3 years, and then discontinued the monitoring because no serious adverse events were developing. In addition to the many thousands of patients who have used them for perhaps shorter periods of time, each agent has been used in a number of patients for over 5 years, and overall the number and quality of these studies is more robust than any other set of studies in any other treatment of ITP, with the possible exception of IVIG. In general, there are not a lot of side effects. If a patient might have MDS, it's possible that especially Nplate could stimulate the appearance of blast cells, though in most cases, if this happens and the Nplate or L-Thrombopag is discontinued, the blasts will regress. L-Thrombopag may create problems with abnormal liver tests in about 1 out of 33 patients. Both adults and children will be unable to tolerate L-Thrombopag for that reason. This is why it's useful to monitor liver tests and obtain them with platelet counts in these patients. Rebound worsening of thrombocytopenia when treatment is discontinued essentially happens with all agents. And while there may be increased reticulin in the bone marrow, this is not true myelofibrosis and is reversible if these agents are discontinued. In my opinion, therefore, thrombosis, which has not been demonstrated to be increased in any of the randomized studies, is the most important problem that you can see with these agents. And if somebody needs treatment to increase their platelet count, but may be at risk of thrombosis, if or as the count goes over 50,000, it can be perfectly appropriate to start a baby aspirin or some other therapy to reduce the risk of thrombosis. In addition, if a patient is on a TPO agent and develops thrombosis, the most dangerous approach is to stop the TPO agent and start anticoagulation, because usually the platelet count will fall quickly, and then you will have an anticoagulated patient with a very low platelet count, and there have been hemorrhagic deaths reported in that situation. Finally, though not indicated on this slide, there are people who develop diffuse aches and pains or headaches with one or the other agents and are unable to continue them, though fortunately this is quite infrequent. These are the robust studies described. The 5 studies in yellow, in addition to one of the pediatric studies, are the 6 largest randomized controlled trials that have ever been done in ITP. What about eltrombopag for adults? These are the first 2 studies on the top, a phase 2 here and a phase 3 here, that were the basis for the initial licensure of eltrombopag. The lower study randomized patients to 3 different doses and placebo and saw a 70% response rate at 50 milligrams and an 81% response rate at 75 milligrams. The second confirmatory study had results that were slightly less good but still highly significant, with a response rate of 59%. Those 2 studies were short-term 6-week studies. The RAISE trial looked at 24 weeks of treatment in almost 200 patients, and you can see that a sustained platelet response was achieved in 60% of patients on eltrombopag and only 10% on placebo. Other ways of looking at efficacy over the 6 months of the study were the number of weeks with a platelet count greater than 50,000 being more than 11 on eltrombopag and only 2.4 on placebo, and the number requiring rescue therapy, which were only 18% for eltrombopag, but were 40% for placebo. This looks at the long-term use of eltrombopag in the so-called EXTEND study. You see it goes out to at least 3 years, and the platelet count can be safely and readily maintained at a platelet count greater than 50,000, which is indicated by the red dotted line. There have now been more patients going out further, and this line and this effect appears to be maintained indefinitely. So again, going back to the questions, highest cure rate is seen with splenectomy. Highest cure without splenectomy is 3 cycles of dex and rituximab, and we would now add MMF, mycophenolate mofetil or CellCept, to it after that. And the highest rate of good platelet counts would be the thrombopoietic agents. How would I use thrombopoietin agents in patients with ITP? And these are opinions, and when we discuss the cases, Howard may feel differently about some of them. So in this case, eltrombopag was tried at 50 milligrams for 2 weeks, but the count only went up to 21,000. Just to be sure that the patient was taking it on a sufficiently empty stomach, we reviewed that, and apparently he was, i.e., more than 2 hours after eating and more than 4 hours after dairy, and no other supplemental calcium or iron within 4 hours of taking the medicine at bedtime. So we went up to 75 milligrams, which is the highest dose, and then the platelet count increased to 80,000 after 3 weeks. Now at this point, the patient had still been on the 20 of prednisone daily, and the prednisone was tapered, and the platelets slowly fell to 40,000 over 6 months as the tapering was done slowly and the patient was followed for additional time. What if we had tried eltrombopag at 75 milligrams and it hadn't worked? Well, because the mechanism of effect is so different, we believe that you can combine them with other agents, and it had appeared in the studies that there was particularly good additive effects or synergy with steroids. The key point would be add another agent, don't stop the TPO agent. And this actually seems to work in most cases. So why are these agents good treatment for ITP? And we showed you data for eltrombopag, but the findings would be the same if we had used romoplostin, except that it requires injection once a week. So these agents are highly effective, perhaps as effective as IV gamma globulin, which made its debut in the early 1980s. The agents are very tolerable, and the issues are either the diet to find a consistent time when the medicine would be taken on an empty stomach, or a weekly shot. Generally, they're safe. As indicated, the main side effect usually is thrombosis, although issues for eltrombopag with liver tests and for both of them with aches are important. If somebody wants to wait and see if their ITP will improve over time, I think generally thrombopoietic agents are good ways to do that. And even though they're thought to be, quote, inert, unquote, the TPO agents may have limited curative effects. Names are confusing, but we've reviewed these already. AMG 531 has 4 identical peptides that have disulfide bridges to an Fc carrier domain. Since the receptor has to be dimerized, having 2 pairs is a good way to do it. And the half-life gets longer. So if we look at the effectiveness here, we see that the TPO receptor here is dimerized by binding to TPO. But this shows how the TPO receptor binds TPO and then signals through the JAK-STAT pathway, the P34 MAP kinase pathway, and through the AKT pathway. Eltrombopag, in contrast, is a small molecule. You can see in the bottom that it's less than 1/100th the size of native thrombopoietin. Because of this, it's orally bioavailable and not immunogenic. We discussed already the issues of diet that are the main limitations of its use. Here the situation looks similar, but when eltrombopag binds to the receptor, it appears to bind in the transmembrane domain. There's a histidine-lysine polymorphism that determines whether or not eltrombopag can bind. And it's believed that it signals the same way, and while there have been questions about the AKT pathway, it seems to signal through that pathway as well. As we talked about, there are many studies with romoplostin as well as eltrombopag, and there has now been a large pediatric study that is in press to the Lancet, and another pediatric study has enrolled almost 100 patients so far and likely will lead to licensure of romoplastin in children the way that L-Trombopag is already licensed. L-Trombopag, in addition, is licensed for aplastic anemia. The hepatitis C data is not as relevant now that there are newer agents to treat hepatitis C and interferon is not frequently used. There were 2 studies of the use of L-Trombopag in children with persistent and chronic ITP, although between the 2 studies, over 90% of the patients had chronic ITP. The first was the PETITE study, which was the initial study, and that was published in July in Lancet Hematology. The second study was called PETITE 2, and this was published in the Lancet in July, and took advantage of the PETITE study to be able to use more accelerated dosing and start at higher doses so that it would have potentially better results. The primary endpoints were different. If you look on the top of the line, you see that PETITE, which was only a 6-week study, had as its primary response goal having one platelet count greater than 50,000. This was seen in 62% of the patients and only 32% of those with placebo. In contrast, PETITE, although this was highly significant with a P of 0.011. In contrast, PETITE 2 was a 12-week study, started at a higher dose as indicated, which is an important point I'll come back to in a minute, and required 6 of the last 8 counts to be greater than 50,000 without the benefit of rescue therapy. This endpoint is like the one that was used for romoplastin in its licensing studies published in the Lancet in adults in 2008. And there you see that only 1 of 29 placebo patients versus 25 of 63 or 40% of the L-Trombopag patients achieved that number, and the P was less than 0.001. Now, if we look here at PETITE and look at the platelet count over time, in all likelihood, the reason that there's a bigger difference in the platelet counts at week 5 and 6 compared to 1 and 2 and 3 and 4 is that children seem to require relatively high doses of medication and therefore required more dose increases before significant effects were seen. In contrast here, in PETITE 2, the separation occurs sooner because the doses in the L-Trombopag arm start higher and increase therefore faster. Of note, 81% of patients in the open label phase following each of these randomized phases, 81% of patients achieved the platelet count greater than or equal to 50,000. In addition, we believe that children, especially when they get an infection, can not only have their count go down, but go up. So some of the higher placebo rates, especially when only 1 count was required in PETITE, demonstrated the effect of an infection being able to give a response. Romoplastin also, as mentioned before, has been used in children and adults with ITP. Here you see in adults long-term response with fairly stable median platelet count out to 3 years. The increased variability later is a result of the fact that there's so few patients that single patient changes make a big difference. Similarly, you can see that there's no evidence of tachyphylaxis, and the higher doses here again reflect not only the small number of patients, but the fact that the first patients into this study, and therefore the ones furthest out here, were everybody's absolutely most difficult patients who entered the initial studies and therefore required a higher dose. There was a pilot study in children published in 2011, and then there was a retrospective analysis between two centers, Children's Hospital of Orange County and ourselves at Cornell, that again saw high response rates in these patients when treated with either eltrombopag or especially romoplastin, as many more patients in these studies were on romoplastin. You see here data from the initial small randomized study showing that there's responses at all the different ages. This later gets controversial because later studies have showed that the youngest age group, which we could define overall, unlike the way it's defined here, as less than 5 years of age, the children less than 5 seem not to respond quite as well to either agent. Long-term studies with these 22 patients have been conducted for many hundred weeks. And you see here going out to almost 5 years that the platelet count is slowly creeping up and the dose is slowly creeping down, suggesting that these patients may be slowly getting tolerized. This is the randomized study of 62 patients with romoplastin that is in press to the Lancet. You see here the platelet count over time increasing as the patient's dose increases 1 microgram per kilo per week until the response is seen. In contrast, the placebo patients are obviously not doing much. So in conclusion on this part of the study, romoplastin had a high rate of platelet response. It didn't show you the data, but there were no new safety signals. Platelet counts could be maintained consistently elevated with decreased bleeding. There were no thrombotic events. In these randomized studies, no bone marrows were performed in children, but in the retrospective study in the Journal of Pediatrics in 2014, bone marrows were performed and the data looked identical to that seen in adults in other studies. And therefore, we think that either of these agents may be very useful in children with ITP. To shift gears for a minute and talk about mechanism, if we look at platelet retics on the y-axis, we see that with 2 different TPO agents, responders had big increases in platelet retics, whereas responders to Winro or to IVIG or to a monoclonal antibody that blocks FcR3, in general there was no significant increase in platelet retics, suggesting that yes, the TPO agents have novel mechanisms of effect stimulating production of more platelets, whereas IVIG and Winro, as expected, reduce the destruction of platelets without stimulating production of more new ones. This study illustrates the induction of Treg activity in patients responding to TPO agents. Tregs are thought to be very important for suppressing immune responses, in particular autoimmune responses. We see here normal healthy controls, and we see here pretreatment patients with ITP who have a higher proliferation because their ability to suppress with Tregs is less. When patients are on treatment, the responders have much better suppression of proliferation, and the non-responders do not. This illustrates that TPO agents may not be as inert, but rather may have important immunologic effects. Another suggested one has been a shift in expression of which Fc receptors are used. Finally, both L-Thrombopag and Romoplastin seem to improve patient health-related quality of life, especially fatigue, vitality, and physical issues, and alleviation of depression not shown on this slide. This slide illustrates bone marrow fibrosis with reticulin, where you can see the black lines that have been laid down in the marrow. It is thought that in certain patients, stimulation of the megakaryocytes in the marrow causes a leakage of TGF-beta into the stroma, inducing this reticulin fibrosis. As indicated, it is reversible. So in closing on the TPO agents, how fast can we get the count to increase? About 1 week. Rate of response, 60 to 90%. Do L-Thrombopag and Romoplastin work the same in all agents? No. Increasingly, there's anecdotal information that patients may respond to one and not the other. What about improvements over time? Maybe as many as 30 to 40 patients appear to be cured or at least improved after 6 to 24 months of treatment. And as we talked about before, since the TPO receptor agonists have a unique mechanism of action, i.e. stimulating platelet production, they work very well with agents that inhibit platelet production in terms of bringing up the platelet count. Remarkably, there's nothing very different about the use of these agents in pediatrics. Not only do children require higher doses, but very young children may require even higher doses, especially of L-Thrombopag. Teenagers and young adults may have more difficulty with the diet restrictions of L-Thrombopag. And a very important point is there's actually a lower risk of thrombosis and MDS in children with chronic ITP than is seen in adults. These agents are effective, tolerable, appear to be generally safe, can be used over long periods of time, and may even have limited curative effects in at least some patients. If we talk about other agents briefly, these are agents that have been in clinical trials, the most prominent of which currently is the Rigel 935788 SYK inhibitor known as fostamatinib. Their trial in the U.S. in 75 patients, 50 on active drug and 25 on placebo, just closed, and the parallel trial in Europe is close to finishing. Other agents are much earlier in their use, and it remains to be seen which ones will emerge as useful agents. So we're going to go to now the two interactive cases, and Dr. Liebman will do the first case in adults.
Thank you, Jim. This is a case of a 49-year-old man with a 16-month history of refractory ITP. And his recent event begins during an automobile accident when he's a passenger, but his airbag failed and he went forward and he injured his left knee, sustained trauma to the left knee, and was brought to the emergency room. As background, his ITP history begins 2 years previous at the age of 47. He responded to initial treatment with intravenous immunoglobulin and 80 milligrams of prednisone, with his first platelet count being less than 5,000. And platelets rose to normal over a 2-week period, but he could not, over the next 6 to 8 weeks, be weaned down off his prednisone, and in fact, when his prednisone dose was reduced to 10 milligrams a day, his platelet count dropped below 10,000 platelets per microliter. At the same time, he had recurrence of bleeding manifestations, predominantly petechiae and some ecchymoses. Now, at the time, instead of increasing his prednisone dose, danazol was added to the prednisone after his platelets were increased with intravenous immunoglobulin. But again, this did not appear to sustain a good response, and so the question emerged whether he should undergo a splenectomy. And he was offered a chance for laparoscopic splenectomy, but he wanted to consider alternate approaches, and his hematologist recommended rituximab therapy for 4 weeks. A question is, as a physician, what would you expect the initial response to rituximab therapy would be, and the response is considered at 1 year and 5-year follow-up? Because the patient really wishes to know what are his chances of having a long-term remission. Would it be initial response at 1 year of about 84%, with a 5-year response being approximately half the patients? Or initial response at about 62%, with a response of around 40% at 5 years? Or an initial response at 1 year, and I'm calling that initial, meaning that what the response would be at least 1 year, at 57%, decreasing to about 34% at 5 years, or 38% and 21% respectively. Well, this has been looked at by the co-chair of this meeting and his group, and they published the data on this. And as you can see in this slide from the paper by Patel in Blood, published in 2012, which looks at a cohort of both children and adults, you could tell this gentleman that at 1 year he has about 38%, close to 40% chance of having a platelet count greater than 50,000. But at 5 years, the chances are that only about 21% chance of having a sustained platelet response. It should be noted that the majority of patients who obtain a response of 1 in 5 at 5 years, most of these patients had a complete response that was sustained at 1 year. So the better initial responders appear to sustain their response. It's of interest and published previously that the patients who appear to have the complete responses do more than just increase their platelet count, but in a study by Roberto Stassi, published in Blood, they reset their T cell repertoire and have increases in their T regulatory cells, which may in fact subsequently suppress the autoimmune response, leading to long-term remission. So this patient decided to try rituximab, and he was treated weekly for 4 weeks with 375 milligrams per meter square, and the platelet count, while on prednisone at 30 milligrams, did increase to 90,000 per microliter. However, over the next 2 months, when prednisone was gradually reduced to 5 milligrams, his platelets fell again to 8,000 per microliter. The patient was given a gram per kilogram intravenous immunoglobulin, and prednisone increased to 40 milligrams a day. So what would you recommend for this patient? He had an initial response to treatment, to prednisone intravenous immunoglobulin, and his platelets, even though he was still on prednisone, did increase when he received his initial dose of rituximab. But after 2 months with reduction of his prednisone, platelet count fell. We should consider dosing him with cyclophosphamide, an effective agent that's known to have responses in other autoimmune diseases. Azathioprine, and the dose that's been classically used in other autoimmune diseases historically. Mycophenolate, a very effective agent, also used in occasional cases of autoimmune disease. The response rates in all of these are really quite variable and only involve case reports or case theories, but approximately a third of patients may show responses when one looks at the literature? Or would you just try to take him down to the lowest dose of prednisone to maintain a platelet count of about greater than 30,000, considering the long-term toxicity of prednisone even at low doses? Or would you consider a thrombopoietin receptor agonist, and the patient not wishing to come in regularly would have considered of the two that were offered to him, Thrombocytopenia, starting at 50 milligrams a day? While taking prednisone at 3 milligrams a day, his platelet count stabilizes between 20 and 30,000, so he chooses initially prednisone, and he decides after that to start treatment with Thrombocytopenia 50 milligrams a day. And on the combination, as previously mentioned by Dr. Bussell, of both steroid and a thrombopoietin receptor agonist, his platelet count rapidly increases to greater than 200,000 per microliter. Not wishing to keep his platelet count at this level, prednisone is gradually tapered over 3 weeks, and after the prednisone was stopped, his platelet count was 70,000 per microliter on 50 milligrams daily of Thrombocytopenia. This chart shows the extend data up to 3 years on the Thrombocytopenia study. And as you can see, very effectively was able to maintain platelet counts out to 3 years. Obviously, the greater variability seen out or fewer numbers of patients on the later periods. But you can see that able to maintain the platelet count at doses of 50 milligrams a day above 50,000 in the vast majority of patients for long-term use with reasonable safety. So for this reason, the patient felt comfortable continuing on Thrombocytopenia up to the time of his admission to the emergency room with trauma to his knee. At the time of the emergency department visit, he had been on a stable dose of Thrombocytopenia for 14 months, ranging from a low of 60,000 to 100,000. In the emergency department, he was noted to have a large 12-centimeter ecchymosis with a obvious large hematoma over his left knee. Platelet count in the emergency room was 52,000 per microliter. Over the knee with motion, X-ray showed no fractures. And he was sent home with a recommendation to limit ambulation, use ice pack over the knee hematoma, and take hydrocodone acetaminophen for pain. The question is do you feel a platelet count of 52,000 is adequate for this individual who has a large hematoma? Would you prefer a higher platelet count and possibly increase his Thrombocytopenia to 75 milligrams a day? Would you might consider adding low-dose prednisone, which we know is synergistic with Thrombocytopenia, and increase the platelet count to greater than 100,000 until the hematoma resolves? Possibly add a inhibitor of fibrinolysis, such as Amicar, 1 gram every 8 hours until the clot resolves. Not change his present therapy. Is 50,000 per microliter more than adequate in a patient like this with a large subcutaneous hematoma? So the patient goes home, and following the recommendation of the emergency department, he calls you and you recommend he stay at home as his physician, as hematologist, on the present dose of Thrombocytopenia and continue to ice the hematoma. He comes in the office 5 days later and states that the hematoma ecchymosis are half the original size, and his platelet count in the office is 77,000 per microliter, showing that in fact he had good resolution of the clot and there was no need to further increase his platelet count. Dr. Bussell will now present a pediatric case and its management.
Thanks, Howard. We're going to look at a 4-year-old boy who has had ITP for 6 months, who initially was treated with prednisone and then every 3-week IVIG. He received the IVIG whenever his platelets decreased substantially, and when they fell very low, he would tend to have bad nosebleeds that would be hard to stop. The IVIG is given every 3 weeks, and severe headaches develop for 1 to 2 days after each infusion. All but which of the treatments below are very reasonable to use at this stage in this child who has had his ITP for 6 months and responds well to therapy but doesn't maintain his count. pulses of dexamethasone, changing over to Winrow in someone who's Rh positive, direct Coombs negative with a very adequate hemoglobin for age. Rituximab, it should be then romoplostin or eltrombopag or splenectomy. After discussion of the options, the family decides to use eltrombopag. The treatment that doesn't seem reasonable would be splenectomy because he can be treated to maintain his platelet count, and there is no special reason to think that this early in the course he should have his spleen removed. The other options are all reasonable, but the family likes eltrombopag. He starts at 50, but then needs to increase it to 75 milligrams daily. The boy gets it at night when the parents go to bed, so he has it on an empty stomach, which is very important, and they make sure he doesn't drink milk with dinner, or at least within 4 hours of when he takes the medicine. His platelets are typically around 50,000. He plays soccer and basketball, and everything seems pretty stable. Now 6 more months on, he is 5 years old, and an attempt is made to taper the eltrombopag down to 50 milligrams daily, but when this is done, the platelet count falls to 10 to 20,000. He has a nosebleed or two again. And now the question is, which treatments are very reasonable to use in this 5-year-old boy? What about dexamethasone pulses? Same story. What about Winrow? What about rituximab? What about either using romoplostin or continuing with eltrombopag? What about splenectomy? And would all of these choices be reasonable? Now that he's 5, and now that he's had his ITP for a year, even though not many people would choose splenectomy, this becomes a reasonable choice. Similarly, the other choices also are reasonable for one reason or another. Even though he's had his ITP for a year, he does not automatically have to try something curative, since he might still get better on his own. He could try to use romoplostin instead of eltrombopag. He could well try the rituximab-based therapy with 3 cycles of dexamethasone. We discussed splenectomy, and Winrow is perfectly acceptable, but he would have to respond well to it, not become particularly anemic, and hopefully only need to get it every 4 to 5 weeks. All of these options could be considered. I think if the family wanted him to be cured, we would encourage them to try the rituximab with dexamethasone. If they didn't want to try anything new, newer therapy, and were concerned about leaving him on eltrombopag, even though there's data in children on it now for years, they could select Winrow and see if it was as easy to use and as effective as they hoped. And it would be perfectly reasonable to just stay on eltrombopag and possibly to consider trying to reduce it again in 6 months, in another 6 months, or another year. Thank you.
Obviously, many patients who are given a diagnosis of immune thrombocytopenia may feel somewhat isolated in a practice of physicians that are predominantly oncologists with some hematology training. And so it's very helpful to find resources that provide up-to-date information and a resource to answer questions in regards to this disease. Fortunately, there is a national group for people with ITP called the Platelet Disorder Support Association. Their ongoing website provides updates on new treatments, and they are very responsive to any questions or queries in regards to questions patients have. They provide a variety of booklets that provide information about the disease that are simple and well explained and have been vetted by experts, internationally recognized experts in this disease. Provide updates and information. They have a variety of support groups throughout the United States and Canada. And in addition, they have a national meeting held yearly in which patients can attend and simultaneously be able to talk with and ask questions of some of the most distinguished experts in the field of immune thrombocytopenia. And this is available here, as seen below, www.pdsa.org. And if possible, support this organization and take advantage of the information provided by them. I want to thank you on behalf of Dr. James Busseau and myself for participating in this ongoing activity. If you have further questions or issues in regards to this information, you can email the site given here, and it will provide a link to access or download any supplemental educational information from this group, including downloading this slide deck for further reference.